So I'm going to talk about big data and genomics in healthcare. It's going to start quite cheesy, and then I will go to more practical, or more practical and explicit things. So we have been living over the last 15 years through this amazing revolution. Some people put up the NHGRI drop in sequencing cost prices. I have a different way of illustrating the drop in price of DNA sequencing. In 2003, Craig Venter raised enough money from the US stock market to sequence a human genome, which we later discovered was his own human genome. He raised about £26 million, and that was the same cost as the most expensive house in London at the time. Now, this is not a picture of that house. You're not allowed to take pictures of the house. This is a nearby house in Kensington. These days, I could get my own genome sequenced for substantially less than an Arsenal season ticket. And it is clearly more value than an Arsenal season ticket for anybody who follows the Premier League. And large numbers of people in London have a Arsenal season ticket, and they could have had their genome sequenced and more for the cost that they put out there. Getting your genome sequence is slightly more expensive than the bottom of the Premiership league. I don't know what the most expensive football team season ticket in Switzerland is, but it will be getting to that scale soon. In other words, it has become a cost that everybody could manage, and certainly healthcare systems can manage. This technology continues to innovate. This is my favorite portable DNA sequencer. I have one in my bag. So this little device here can sequence infectious disease genomes very credibly, and they've done it in Antarctica and in space. Certainly all the clinics in Switzerland would be entirely achievable to have a device that would give you a readout of infectious diseases. Notice I'm a consultant to this company. And just to say, the other big technology shift that has been going on over the last 15 years has been imaging. And this goes from the EM scale, so the atomic scale, through to organismal imaging, very exciting ways of playing around with photon optical procedures in the middle, light microscopy in a variety of ways. As well as the techniques having better resolution, the real other big shift is imaging has become very, very quantitative. 10 years ago, the output of images were mainly presented to scientists who looked at it and then made a decision about what was going on in the image. And these days, one does a lot more direct quantitation and modeling on the image and derives measurements directly from the image of a variety of sorts. And all of this has meant that there's been a very, very big impact on research. So when I was growing up as a researcher, most of it was done in the wet lab, kind of advanced cookery of some kind of manipulating molecules to make inferences of the world. And these days, you do as much on your computer as you do in the wet lab, and you make inferences using statistical techniques. This isn't going away, but at least it's becoming about 50-50 emphasis between these two sides when you execute science. And this shift to a lot more data-driven science does cause a change in the way we do science. And some of this is basically statistics. It's effectively multivariate complex statistics and machine learning. But I want to just put a plea in here that we also have to really strengthen our data engineering. There's a lot of analogies with CERN, where when they had to move and upscale their experiments, they had to internalize a lot of engineering into their scientific discipline to achieve that. In biology, we have to internalize data engineering into our discipline, and it's different from statistics. It's different from research to build out these very big, complex data flows. And then that's just an introduction to the Institute, which I'm a director. Some of you I know will know this, but just in case for the people who don't, EMBL EBI were part of the European Molecular Biology Laboratory, which is an intergovernmental research organization. We're based just south of Cambridge in Hingston. Importantly, the EMBL treaty is not one of the EU treaties, and therefore our relationship does not change regardless of how much politicians in the UK screw up the process coming up. I'm sorry about the slides flipping forwards. And we do big data. We've been doing big data before it became trendy, and we will do big data afterwards. But what I want to do now with that kind of intro of the change, mainly in research, is indicate how this is changing how we think about medicine. So, as I mentioned, genome sequencing is now cheap enough. It's about $200 to $300 per exome, about $800 to $1,000 for whole genome. Some have got it down cheaper than that. There is a line of sight on $100 genomes. It's very clear that one should predict that that will occur over the next 5 years. There are now more costs in gaining consent and the interaction with the patient, DNA sample acquisition, and then I should put a plug-in for storage and standard analysis. Compared to these things, this is low, but the important thing, it's not zero. That's the very important thing to realize. These things, genomes don't analyze themselves. People have to do that. And the all-in costs are below routine medical diagnoses, for example, MRI machines. So if you're a hospital system and you run MRI machines, you should be a hospital system running genomic medicine. And there is strong clinical utility now. The best place to get this is from rare diseases. So between 1% to 2% of children are born with a likely genetic-based rare disease in nearly every country around the world. And when you sequence a child's genome and their parents with a suspected genetic disease, these days, about 30% of the time, you get a diagnosis for that child. Now, very rarely do you change the outcome for the child. It does happen, and it's wonderful when it happens. But importantly, you really improve both the child and the parents' experience or life by ending this otherwise quite painful diagnostic odyssey. And so there are very, very big benefits to the child's life and to the parent's life by making an accurate diagnosis. It also opens up reproductive choices for the parents, and in particular, about 40% of the genetic diseases are due to a de novo mutation. And when you can make so that a mutation that's only arisen in that generation, and when you make a confident diagnosis of a de novo mutation, you can counsel the parents that they are not likely to have a recurrence of the same disease if they have a second child. And there's good evidence now from this study in Australia that this really works. It's cheaper, it's about the third of the cost, it is more effective, it's about 5-fold more diagnoses, and it has better outcomes for the children and the parents. For example, the parents who get a diagnosis are far more likely to have a second child and a much more fulfilled family from this process. So I see no reason every single modern healthcare system should be implementing exome or genome-based rare disease genetics now. There's no reason not to. As Ashok mentioned, cancer is the other big area, and cancer is much more complicated. I don't think there's a single cancer researcher that doesn't believe that it's going to be useful and informative and powerful, but the logistics of cancer are much harder, and also the fact of diagnosis doesn't tell you much. You really want to affect treatment options, and so the research, clinical research, is much harder here. However, for things like HR Detect that Serena made, and other techniques in a variety of trials and that you can, depending on the trial, this changes, but the one I'm comfortable with is 1 in 10 patients have treatment-changing information from when they get cancer genomic information. And broader molecular phenotyping via genomes is showing promise, and Ashok mentioned this for example, these signatures, these BRCA1, BRCA2 non-homologous repair genes. And this has all led to serious efforts across the world, many of them in Europe, and in particular, I would highlight Genomics England, which is the UK's NHS process of implementing genomic medicine inside of the NHS. And they are about to move from their starting project, which is called the 100,000 Genomes, to their business as usual project, which will kick in from 2021 or 2020 onwards, I believe. And they're aiming to sequence 60,000 genomes a year on the basis of that business as usual project. There's a well-developed plan in France, Plan France Génomique, and the first sites have been selected, which perhaps unsurprisingly are Paris and Lyon, to deliver sequencing. Iceland is a bit of a special case because of really the vision of one individual, Kari Stephenson, who put together the power of genomics and genetics in Iceland, but they are using it now more actively in healthcare. And I have put Switzerland here. Maybe I should put this is the wrong logo, isn't it? SPHN. I need to update my slide. It's some portmanteau of the two cases, but I have learnt a lot from being in the audience here. And if you model the numbers of patients who are likely to get genome diagnoses over the coming years, it is going to be an incredibly large number of people worldwide. And for researchers, this is very important. Healthcare is a huge industry across the world, and this huge industry is now going to molecularly measure these amazing wild organisms called humans. And humans are really good organisms for us to study. They have all the normal things that a mouse have. So if you do mouse biology, humans are great. And they're very, very good organisms to study human disease. And we have a huge opportunity as researchers to have gobsmacking numbers of humans being measured around the world. But there is a big gap about bringing research and medicine together. And in fact, for me, it's most obvious when I go to other European countries. Like today, many of the talks when I go to Berlin or I go to Paris or what have you, many of the conversations I have with the leading healthcare people in those countries are in English. However, the directions to the office and the ability of how you sign in at the bottom of the thing is nearly always in French or in German, or in this case in 5 languages, or however many is necessary for Switzerland. And the reason why is because healthcare has to be practiced in the national language and can't be practiced in the international language of science, which for me, very luckily, is my own mother tongue, English. Now, this is just one difference between research and healthcare. There are many, many others. And one thing to realize as we build these bridges between research and healthcare is just acknowledging the fact that we've got two systems that are wired quite differently when we build this bridge. And for a long time at the EBI, we have realized that our science can only go so far. We are an international treaty organization. We operate in English. We do not operate under any national legislation. And so it's absolutely critical that there are nationally based schemes that we can build a bridge to transfer our technology into the healthcare systems, certainly of our nation states, but also more broadly. And so for a long time, we have argued that there should be an Institute of Biomedical Informatics in each country. In large countries, in large nations, or in nations that aren't that large but are passionate about their local democracy and the federalization of them, it is inevitable that this will be a federated network inside of the nation. You just can't get around it. But it's going to be impossible to interact sensibly worldwide without a center of gravity. And we hope to handle research data, reference collections, and sharing amongst researchers, including clinical reference information, including the clinical, what does it mean to be diabetes or diabetic or something like that. But the bioinformatics and medicine institutes, we hope, will be responsible for exploiting that in the countries and broker research, anonymized research, back into the systems. And this is just to mention, just to introduce this amazing organism. Humans, we're outbred, we're big. If you're a researcher, there is a huge opportunity in humans. Humans are really becoming an amazing model organism to study all sorts of things, not just human disease, but also very basic fundamental biological processes. And there's this amazing thing that they take themselves to hospitals to be phenotyped. You can't persuade mice to do that, for example. But this process also are going to need standardizations of the way we share data, because implicit in everything we do here, healthcare data will not be aggregated in single locations across the world. Research data can be aggregated, but healthcare data really can't be. There are practical reasons, it's too big, but more importantly, there are legal and social responsibilities. Denmark will not say, that's fine, please ship the entirety of the Danish medical system to China so that Chinese researchers can play around with it. It is not a responsible thing for the Danish government to do. And so we need to shift, as Torsten mentioned, about inside of Switzerland and having Docker images move between different places. That also needs to happen internationally. And for that to happen internationally, we need a standard setting body. And I'm very proud to be the chair of this organization, the Global Alliance for Genomics and Health. We embrace this federated approach. And the analysis is carried out where the data lives rather than the data moving around the world. If you're doing genomics, by the way, we're also the people who look after this set of formats. If you don't, this looks like gibberish. Apologies, but this is kind of geeky genomic stuff. So we go from the geekiest end to the most big scheme end. And again, I think for research data, we will continue to do this aggregation, and it will be incredibly important that that aggregation is continued for the benefit of the world. The reference human genome is a great example of that open reference aggregated data that the entire world uses. But for healthcare data, we will not be allowed to aggregate patient-level data across multiple countries at scale. And so we must have systems where the analysis goes out to different locations. Here's someone based in Brazil sending something both to two sides of America, maybe to the UK, maybe to Switzerland and Japan, to execute a particular analysis of a particular rare type of cancer where the analysis will unfold in each of those locations. And I'm very delighted to say that the next plenary meeting of GA4GAH will actually be happening in a city, a small train journey from here, so lovely Basel. And many thanks to Ron Apple and Torsten Schweder from SIB for co-sponsoring this, the Swiss Institute of Bioinformatics, and for Elixir, which is the pan-European bioinformatics framework that we, EBI and SIB and other partners are all part of, for this Global Alliance plenary happening. Please send your data controllers, your technical people to this meeting. They will learn, I hope, a lot about this global standard setting process. So thank you very much for listening, and I'm not quite sure what happens next.
Oh, it's okay. It's me. Thank you very much.